Hello, and welcome to today's presentation on the management of infiltration and extravasation, presented by Raymond Villar and Daniel Roy from the Albany College of Pharmacy and Health Sciences.
So the objectives we'd like you to take away from this presentation are: we hope that you understand the differences between infiltration and extravasation. We hope you know the initial treatment for both of them. We want you to be able to identify the risk factors associated with infiltration or extravasation. And by the end of the presentation, we hope you understand the various treatment options that are available.
We incorporated this slide just as a disclaimer for the presentation we are about to present. This slide is incorporated because most of the data supporting treatment of extravasation and infiltrations is based on theory and not on well-supported clinical trials. What is infiltration and extravasation? Infiltration is the leakage of non-vesicant solution from the vasculature into the surrounding tissue. Non-vesicants do not directly cause tissue necrosis. Extravasation is the leakage of vesicant solution from the vasculature into the surrounding tissue. Vesicants directly cause tissue necrosis. Overlap between both injuries occurs when large volumes of infiltrate result in acute limb compartment syndrome, which can result in the loss of arterial perfusion, causing tissue necrosis and ischemia.
So the signs and symptoms of infiltration include swelling, discomfort, pain, tightness, cool skin, and skin blanching. So for those of you that don't know what skin blanching is, that is when your skin turns white, mainly due to vasoconstriction. So what happens is when you have this infiltration, you get that vasoconstriction, which causes the tightness. That also makes your skin turn white and makes it cool to the touch, mainly because the area that is infiltrated is not able to perfuse properly. So the signs and symptoms of extravasation include swelling, discomfort, and pain, which is also seen in infiltration. The differences are: extravasation has warmth, burning, erythema, blistering, and tenderness. This is because you have that leakage of vesicant into the surrounding tissue. The vesicant causes inflammation and skin irritation, which you can see in this picture on the slide.
Next, I would like to discuss the non-pharmacological risk factors for infiltration and extravasation. Most of these risk factors have to do with veins and mechanical injury. So small fragile veins, large catheter size, especially in relation to vein size, placements at areas of joint flexion, patient activity, probing during placement, extended device dwell time, misplacement, poor catheter securement, and rate of infusion. This is especially important when looking at pumps versus gravity. The bottom line is anything that can cause physical damage to the vasculature can increase the risk of infiltrations and extravasations.
So how do we prevent infiltrations and extravasations from occurring? Well, you want to avoid veins in the hand, wrist, and antecubital fossa. You want to avoid these veins because their location can cause some complications from catheter movement. The veins in the forearm allow bones to act as a splint and are usually recommended over those other areas. You want to make sure that an appropriately sized catheter is used. The smallest gauge catheter for delivering the prescribed therapy should be used. The use of a catheter that is too large for the vein will result in obstruction of blood flow and could cause thrombosis. You want to make sure that you aspirate from the catheter prior to injecting vesicant. You also want to make sure that the catheter is stabilized. It is not recommended to use tape because tape does not stick well to the plastic catheters. Instead, it is recommended to use a manufactured stabilization device such as a stat lock. You want to check for infiltration by applying a tourniquet. This method works because you apply a tourniquet just above the catheter site, and what happens is that it obstructs the flow of blood. So if you see that some of that fluid is actually infiltrating, then you know that you should stop the infusion right away. You want to make sure that you teach the patient to report any discomfort, pain, or swelling, and you want to make sure to cease the infusion and administration if the device is difficult to flush, if pain is experienced, or swelling is observed when flushing.
Next, I would like to cover the pharmacological risk factors for infiltration and extravasation. These include pH, osmolarity, which is concentration, vasoconstrictor potential, and cytotoxic potential. As we all know, extremely basic and acidic compounds can be damaging to cell walls. If one is to infuse a very acidic or basic compound into one's body, you run the risk of damaging the endothelial cell lining of the vasculature. Ideally, infused solutions should be as close to possible as the physiological pH, which ranges between 7.35 and 7.4. However, this is not realistic. So in practice, infused solutions should have a pH of about between 5 and 9. Osmolarity. Osmolarity is related to the concentration of the drug and ions in the solution of the IV. Hyperosmolar solutions cause a shift of fluids from within the cells to the extracellular environment, thereby disrupting cell function and resulting in localized increases in swelling and pressure. Conversely, hypoosmolar solutions cause a shift of fluids from the extracellular environment to the intracellular environment, resulting in cell rupture and lysis. Ideally, infused solutions should be close to physiological osmolarity, which ranges between 285 and 310 milliosmoles per liter. Realistically, this is not the case. The upper limit for a peripheral IV should not exceed 900 milliosmoles per liter, and ideally should be less than 500. The minimum lower limit for a peripheral IV is 1/2 normal saline, which is 154 milliosmoles per liter. Some pharmacological agents in which we infuse by IV can cause vasoconstriction of the vasculature. Such agents can result in ischemic necrosis through constriction of smooth muscle within the vasculature. Such agents include dobutamine, dopamine, epinephrine, norepinephrine, and vasopressin. Additionally, substances with high electrolyte concentrations can prolong the depolarization and contraction of pre- and post-capillary sphincters, thereby prolonging exposure and enhancing the ischemia. Such products include calcium chloride, generally greater than 5.5%, and sodium chloride, generally greater than 3%. Pharmacological agents, such as those used in chemotherapy, can directly cause cellular damage. These agents fall within two broad categories. Non-binding vesicants, which do not directly damage DNA within cells, cause immediate tissue damage but are easily metabolized by the body and cleared rapidly from the site of infiltration. Conversely, binding vesicants, which could cause direct damage to the DNA within cells, cause immediate tissue damage and are not easily metabolized, and their effects are long-lasting. When reporting infiltrations and extravasations, please include the following: insertion site, catheter gauge and length, drug and diluent, interventions, infusion type, extent of injury, and the rate of infusion.
So we're just going to go over a couple of examples that actually occurred. So we have a 66-year-old male on the med-surg floor whose IV began to infiltrate. It was actually graded a level 4. Patient stated that his IV site to the left AC was becoming painful. The IV fluid was discontinued, which was lactated ringers, and upon assessment, the IV site was puffy and firm. The area around the catheter insertion was reddened. The IV site was removed and a warm compress was applied. Now, what were the things that were not done in terms of reporting? So the things that were not reported were the catheter gauge and length, the type of infusion, and the rate of infusion. These are all important in documenting this actual event so that all the information is known. Our next example is a 33-year-old female in the emergency department. Patient's IV began to infiltrate. She was a multiple stick patient and had to be stuck 3 times before a successful IV was put in place. An ultrasound was also used. After 2.3 liters of normal saline was infused, a small amount of fluid started to infiltrate in the patient's right arm. The infusion was stopped and the arm was elevated and pressure was applied. So what are the things that were not reported in this patient? The things that were not reported include catheter gauge and length, infusion type, the extent of the injury or the grade of the injury, and also the rate of infusion. Our next patient, we have an 84-year-old female in the emergency department whose IV began to infiltrate. The patient had poor vascular access and was difficult to draw and required multiple IV attempts. A successful attempt to the right forearm infiltrated while administering the Latin or phenytoin, 1250 milligrams in 100 milliliters of normal saline over 1 hour. The patient required 3 more attempts before the nurse supervisor was called. The nurse supervisor was unable to gain IV access. Anesthesia then tried 3 more times and was successful in the patient's right foot. So what were the things that were not reported in this patient? The things that were not reported include catheter gauge and length, infusion type, grade level, the type of intervention, if one was done, and also the rate of infusion.
The following is the preferred treatment protocol for dealing with an infiltration or extravasation. First, and most importantly, stop the infusion. Next, leave the catheter in place and try to aspirate as much infiltrate out of the injection site as possible. Third, with a pen or marker, outline the size of the infiltration or extravasation so in the future we can assess whether the infiltration or extravasation is expanding in size or is resolving. Next, elevate the site of injury. And finally, evaluate if this patient is a good candidate to receive warm or cold compress, or if there's an antidote for the medication infused.
So these are the different treatment options that these studies have shown or have tried, but we are going to mainly focus on the 4 that are highlighted with stars. Those are mainly the ones that are going to be used at Porter Hospital. These other ones aren't going to be commonly seen, especially dexrazoxane, mainly because that is only seen in chemotherapy. So what is the rationale behind using a warm compress? A warm compress enhances vasodilation by increasing blood flow. This increases the amount of interstitial tissue that is in contact with that infiltrated fluid, thus enhancing dispersion of the agent and decreasing drug accumulation in the local tissue. It is recommended to use an infiltration of non-DNA binding vesicants, and generally it is applied for 20 minutes every 6 to 8 hours for up to 3 days. So this is pretty much how to prepare a warm compress. First, you want to place the compress in hot water until desired heat is achieved. This should not be longer than 10 minutes. Alternatively, you can place the compress in the microwave for about 20 seconds on normal. You want to ensure that the hot pack is not too hot prior to applying to the site. If it's not hot enough, you may continue heating in the microwave in 10-second increments. You may also use instant heat packs if you have them available. So what is the rationale behind using a cold compress? So by applying a cold source to the extravasation site, it causes vasoconstriction, which localizes the drug. This does not allow the drug to spread into any additional tissue and limits the amount of tissue that is affected by this fluid. This is mainly recommended for extravasation of DNA-binding vesicants, except mechlorethamine. It is mainly used in contrast media and hyperosmolar fluids. It is generally applied for 20 minutes every 6 to 8 hours for up to 3 days. The common drugs seen with cold compresses include acetazolamide, acyclovir, vancomycin, vasopressin, and piptazo, or Zosyn. So this is how you would prepare a cold compress. You would place it in the freezer for at least 2 hours prior to use. You want to wrap it in a light towel before placing cold pack to the required area. You want to make sure that you do not apply this directly to the skin. You also want to apply for no longer than 15 to 20 minutes. You can apply it 4 times a day for a max of 48 hours. You want to make sure that you monitor the skin for marked increase in redness, swelling, pain, and edema. You may also use instant cold packs if your institution has them available. One of the agents that you may use as an antidote is known as hyaluronidase or amphidase. What this is a protein enzyme that works by causing rapid spreading of the injected fluid into the body, which increases the absorption of that injected fluid. This increases the tissue permeability, which facilitates systemic absorption of infiltrated vesicant agents. It rapidly results in diffusion of extravasated fluid over an area 3 to 5 times larger than an area untreated. Tissue permeability usually is restored within 24 to 48 hours. It is recommended in extravasations of DNA-binding drugs, non-DNA binding drugs, irritant drugs, hyperosmolar solutions, and many other agents. You'll want to make sure that you do not use this antidote with dopamine or alpha agonist drugs. So the dose for hyaluronidase in a patient that is experiencing extravasation is generally 150 units per milliliter. This is split up into 5 0.2 milliliter injections given intradermally or subcutaneously at each of 5 sites of the edges surrounding the affected area. This should be used within about 1 hour of extravasation. So the common uses for hyaluronidase include concentrated calcium, phenytoin, aminophylline, nafcillin, potassium chloride, sodium bicarbonate, and amiodarone.
The last agent we will discuss today is phentolamine. Phentolamine competitively blocks alpha-adrenergic receptors to produce antagonism of sympathomimetic vasoconstrictors. Simply put, phentolamine results in vasodilation of the vasculature, preventing potential ischemic damage. The dose for extravasation is generally 5 to 10 milligrams diluted in 10 to 15 mLs of normal saline. This is injected subcutaneously into the area of extravasation as 10 1 ml injections. Ideally, this should be used within 12 hours of extravasation. Phentolamine is approved for the reversal of the following agents: dobutamine, dopamine, epinephrine, norepinephrine, phenylephrine, and vasopressin. This concludes today's presentation. If you have any questions about infiltrations or extravasations, or what treatment options are available for a specific drug, please do not hesitate to contact the pharmacy. Thank you. References.